Okay, thank you for coming this afternoon or morning, depends on where you are. My name's Sandy Young. I'm a ACVNU resident, and today I want to talk about sodium bicarb as an alternative to heparin for lock solution. So sorry, how I started to look into alternative solution, that started from one of my patients. Her name's Gwen. She was a rescue from a more like abusive situation. When she came to me, she was 5 year old. You can see she was quite emaciated when she first got rescued. Her new mom, took very good care of her. So when she came to see me, she actually looked better. She gained some weight. Her skin looks great, but unfortunately, she came to see me because pretty severe AKI. We're suspecting she had some chronic kidney condition because based on the ultrasound and previous abusive situation. Despite the medical management, she did not improve. So we did put her on dialysis for, I want to say maybe 2 weeks most, because after the first 4 sessions, she started to have pretty severe hyperkalemia. And after I ruled out other possibilities, because I look into the diet, any supplements, how's my prescriptions, like something I add too much potassium when I put a patient on hemodialysis, it's none of that. Then realized potentially is related to heparin-induced hyperkalemia, which is well documented in people, mostly because heparin can suppress aldosterone synthesis. And there's only one case report in a dog receiving CRRT back in 2015. And usually in people, at least in people, it tends to occur 4 to 5 days after heparin administration, tends to peak around day 7. And as far as we know, mostly in people, it's only happened in the heparin is not, this is not the only issue with heparin. Heparin can also has heparin-induced thrombocytopenia that we know better about. It is a immune-mediated adverse reaction because IgG binds to platelet 4 factor and heparin complexes, which can activate the platelets. And so you will see those thrombocytopenic patients, but they have thrombotic events. They tend to happen around 1 to 2 weeks after initial heparin administration, then one day if it's re-exposure. And also it tends to happen in unfractionated heparin. And the treatment usually just stop the heparin. Either you try regional citrate or low molecular weight heparin. The other side effect from heparin can be skin necrosis. It is very rare incidence in humans, only few case reports in people. They can really have this like a dark, almost like Asgard looking skin in those patients. But there was no case report in veterinary medicine. As far as we know, we suspect it is an immune-mediated reaction, either with or without heparin-induced thrombocytopenia. So, long story short, this is why I started to look into like, okay, what other alternatives can we use for animals receiving dialysis, but they do not tolerate heparin. So, in human medicine, they really start looking to alternatives to heparin, especially during the time of COVID, because there was a huge shortage during COVID for heparin. And they also worry about the cost because heparin sometimes can be quite expensive and sometimes it can hard to find a heparin. Then lastly, the environmental effect. So what would be some good lock solution as alternatives? The purpose of lock solution will be definitely we want to use them to prevent catheter lumen thrombosis because that's essentially the number one reason. plus minus catheter-related infection. So if we can prevent infection while we prevent thrombosis, that will be ideal solution. Some options will be trisodium citrate. And in human, they also use antibiotic locks with the gentamicin, vancomycin, cefazolin with citrate or low-dose heparin as a combination. As I was doing my research, there's a newer drug called Defencath, which is a amino acid taurine derivatives, taurolidine, I cannot say it right. And it just recently approved by FDA in 2023. So essentially, the Defencath is the taurolidine plus heparin combo, but the cost is quite high because if I do a quick search for the price, it's usually about $30 to $60 per cc per ml. I do not think that will be a practical option for our patients. So those lock solution, if we wanted to prevent catheter lumen thrombosis at the same time to prevent infection, sometimes they can be quite expensive. And if we actually use antibiotics in combination with heparin or citrate, we also worry about the antibiotic resistant strains. So currently, the standard care for catheter care will be heparin, mostly unfractionated heparin. But heparin sometimes is being reported to have and to antagonize the bactericidal properties of some antibiotics and likely to promote the biofilm formation in some studies. So and then also the other factor I mentioned earlier in 2 slides ago, why we're looking to alternatives to heparin, because the environmental concerns. I actually didn't know how is heparin made until when I started to prepare for this presentation. So heparin, how is heparin made? It's from intestinal mucosa of pigs. And one pig they can yield about 650 mg of crude heparin. Like in the picture, it is the actual, the manufacturer, the factory, they are processing the pig intestine to produce the raw material for heparin. So for one pig, we can have maybe up to 65,000 international units of the NT28, 2A and NT10A activity. And if we put it into more like a practical number, an actual number, that roughly means one pig has to be slaughtered for every 13 dialysis session in people. Human people are bigger than our patients, so I'm guessing for our patient, probably say for 20-ish dialysis session, we have to slaughter one pig for about that many sessions of the dialysis. So if we have a CKD patients, a dog needs thrice weekly dialysis session for maybe 2 to 3 months of treatments, perhaps one pig was slaughtered because of the dialysis we are treating for the patient using for the patient. Not just slaughtering the pig, but also the carbon footprint is a concern because for every pig, raising a pig, it's about 670 kilogram CO2 carbon footprint. Then the alternatives comes to looking into citrate and also, of course, bicarbonate. So the citrate is from the plants, either beets or corns is the majority plants that are being used to produce citrate. Produced via fermentation, it does have much lower carbon footprint. It's about 1.5% of the heparin production. For bicarbonate, it's from salt and limestone and is produced by Solvay process. Please do not ask me what a Solvay process is because I have no idea. But it requires heat and produces CO2 and ammonia. It does have a higher carbon footprint, but it's still significantly lower than heparin. Based on the resource, like sources that you look it up, it's between somewhere like a 3 to 8 to 9% of the heparin carbon footprint. So both citrate and bicarbonate, they have much lower carbon footprint and is more environmental friendly than heparin. And also they are cheaper than heparin. So because back in COVID and the physicians started looking for alternatives, so they started looking to bicarbonate as a lock solution. They think it's a reasonable medication to try because based on some previous studies, sodium bicarb does have some anticoagulation properties because sodium bicarb can chelate the calcium, which indirectly inhibits clotting. Also, sodium bicarb has some anti-infective properties. It can decrease bacterial adherence and prevent biofilm formation. And lastly, because sodium bicarb has abundant ion, a lot of ions in it, it can stimulate global changes in bacterial structure, gene expression, and membrane permeability. So that's why physicians started looking to bicarb. The very first study I can find in human medicine using bicarb as a lock solution was in 2017. It is a study from a single hospital, center hospital in New York. They basically using saline to compare with bicarb. The first case series, they have 100 patients. I apologize, the graph in the left is very blurred because I don't have the actual access to the paper, but I can find the picture, so I take a screenshot of it. But what we can see is they look into the number of lost catheter due to clotting, and the patients receiving sodium bicarb as lock solution has much lower, significantly lower catheter loss due to clotting. And the same group of physicians from New York, because essentially they want to see if bicarb can, one, prevent clotting, and two, can it prevent catheter-related bloodstream infection. But in the 2017 study, they did not have enough patients for them to look into bloodstream infection. So the same group of physicians, they published a second study in 2019 with more patients, 452 patients in 2019. So they were able to look into saline versus bicarbonate and the relationship of the CRT, means catheter-related thrombosis, and CRBSI means catheter-related bloodstream infection. So for both, sodium bicarb had significantly lower incidence of having catheter-related thrombosis and catheter-related bloodstream infection than saline. But of course, we don't really use saline for our hemodialysis catheter as a lock solution. But one thing interesting to know from this paper is, because I was trying to look for if there's any side effect reported from those papers. Based on what I can see, no side effects being reported in those 450 patients. So at least it's safe to say sodium bicarb is safe to use and is better than using saline. And this is the paper I actually want to talk more in detail about today. It is the 2024 study. It's a study they compare sodium bicarb to classic heparin as a lock solution for non-tunneled dialysis catheter. So the aim of the study is to see the effectiveness of sodium bicarb as a catheter lock solution compared to heparin in non-tunneled catheter. So which is pretty similar to our setting because most of our patients will have a non-tunneled, non-cuffed catheters, a shortened catheter essentially. It is a single-centered, single-blind, open-labeled prospective study. It's from 2021 March to 2022 March. They had about 426 patients. They must be 18 or 18 years older to receive hemodialysis due to any cause of AKI. who needed non-tunnel dialysis catheter. So they use either heparin 5,000 international unit per ml or sodium bicarb 8.4% without dilution as lock solution. As far as for study design, they divided those group into whether you have femoral access. If a femoral access, it will have a longer catheter, is 20 centimeter. If it's a jugular access, will be a little bit shorter, 15 to 17 centimeter. And they either use Fresenius 4008 or Gambro AK96. Their prescription is they standardize their prescription except for the first session because depends on how severe the patient is, like azotemia is. But then for the subsequent sessions, they standardize it for all the patient will receive blood flow about 300 ml per minute with dialysis rate, blood flow 300 and the dialysis flow rate is 500 ml per minute. And this is how they divided their group. They initially had 439 patients, but after exclusive criteria being applied, they have end up 426 patients. They divided those two group into two groups. One is jugular group with 226 patients, and then half of them received bicarb, half of them received heparin. And there's 200 patients had femoral access, and also half of them received bicarb, half of them received heparin. And for the statistics wise, they first use some normality check to make sure the data were roughly bell curved. And then after they check that normality, they use either student t-test, not either, they use student t-test and Mann-Whitney test to compare the jugular and femoral groups with respect to two different treatments. There is a typo in this paper because they write bicarbonates times or X heparin, but it should be bicarbonate versus heparin. Then they use chi-square test for categoric variables. They also plan ahead of time to plan how big the group they should have, how many patients they should have. They decided they should have at least 420 patients, which they did. They have 426 patients and they divided into 4 groups. The result, they have 426 patients. And when looking into the patient characteristics, including the drug affecting coagulations, because some of the patients are receiving like aspirin, some of them receiving clopidogrel for other underlying diseases. Overall, there's no statistical differences between the bicarb and heparin groups, including the age, primary disease, mean BUM, mean creatinine, and other parameters, except the glucose, but it's overall, there's no statistical differences. As far as for how many hemodialysis sessions or the mean duration of catheter use, it varied widely, but between the bicarb and heparin groups, there were no differences. Also, for the blood flow and transient patency problems, there's no differences between two groups. The only significant findings in this part in here is in the femoral catheter groups, the first measured venous pressure was significantly higher in the heparin group than bicarbonate group. But it's the subsequent venous pressure, there were no differences. So we do not know the significance of that first measured venous pressure differences. Also, they didn't really discuss or dive into that too much in the discussion area. The other thing they look into also is the access site infection. Overall, there were 7.5% of the patient has exit site infection. But if we compare between the heparin and bicarbonate group, there's no statistic differences between groups. Then if we're looking at table 4, that's the table they put their primary and secondary outcomes in all groups. They look into the catheter with blood flow problem as the outcomes and also complete catheter dysfunction and exit infection. So if we compare between the heparin and bicarbonate group, we can see based on this table, none of there are no significant differences between the bicarb and heparin groups. But I was looking also curious about like, while it looks like the femoral catheter groups has much lower incidence as percentage wise. So I'm like, well, based on this paper, does that mean the femoral catheter groups is better than jugular group? Which I later realized they didn't really talk about it, but it's just more like my mental exercise. And later on, I look into another figure they have in the paper. It did talk about the patient, like how long, mean of the total days until the last hemodialysis session. In the jugular group, it's much longer than the femoral group. I shouldn't say much longer because they didn't run the statistics on that. So I couldn't tell you what's the p-value, but based on the figure, it looks like the jugular catheter group treated longer than the femoral catheter group. So go back to what I observed in table 4. I don't think I can draw a conclusion and say the femoral catheter groups has a lower incidence of catheter problem. Also, they didn't really compare them, so I cannot make a comment of that. Just in case you're reading the paper, you're wondering the same thing I'm wondering. No, we cannot say femoral catheter is better than jugular. Okay. So a discussion. So in this study, overall, the major finding will be the catheter losses due to thrombosis is about 3.3% in heparin group versus 2.3% in bicarbonate group. Overall, there was no statistical differences between two groups. And in a discussion session, this paper did talk about, refer to a lot of other papers published in the past. So they did mention this paper published in 2021. This paper also looking to bicarbonate as a lock solution versus heparin. However, in this 2021 paper, they have to terminate the study after 6 weeks because there are 40% catheter-related thrombosis in the bicarbonate group versus 0% thrombosis in heparin group. So there's a big contrary between this study and the current study we're looking at. But if we look a bit closer to the study design, the current study is much shorter. It is a non-tunneled catheter, and the mean time of catheter days in the current study is about 11 days in jugular groups and 6 days in femoral groups. But in the 2021 study, the mean time to first catheter-related thrombosis was almost 24 days. So they used the catheter much longer in the 2021 study. So it's kind of hard for me to compare one to the other because one is a short-term use catheter, the other one's a long-term use catheter. So what I can get as a conclusion for myself is maybe bicarbonate is effective in short-term non-tunnel catheter than long-term catheters, but we definitely need more study if we are going to use bicarbonate for a long-term use. The other thing they talk about in the discussion session is they also listed a couple other study talking about using trisodium citrate. So one paper they refer to is they say literally in the discussion session they stated bicarbonate had a lower incidence of catheter thrombosis than 4% trisodium citrate for non-tunnel hemodialysis catheter. So I was a little bit surprised to read that. So I actually find the paper to read it myself. Unfortunately, it's a big mistake because the citation is incorrect. The paper they refer to did not look into bicarbonate. The paper they refer to look into heparin to compare to trisodium citrate. And the conclusion from the paper is there's no statistical differences of catheter-related thrombosis between the citrate and heparin. So this paper is not perfect and also has a lot of typo and citation mistake. This is one major one. Um, so, but then anyhow, they talk about other papers. They also look into the saline versus bicarbonate study, which was the study I talked about earlier. So there's a lower incidence of catheter thrombosis by using bicarb than saline, which we already talked about. And they also talk about another paper. It's a They essentially use ethanol as a lock solution, um, mostly because those four pediatric patients, they have it is central line. It is not a dialysis catheter for feeding for the total parenteral nutrition. So they use ethanol to lock those central line, and they did not notice any adverse event, which I found it interesting, even though it's totally irrelevant to our patients, because I don't believe anyone will use ethanol for lock solution for our hemodialysis patient. But it's just interesting to read this discussion section. Overall, I felt that we can probably say, yeah, bicarbonate, based on the paper, bicarbonate works equally well as unfractionated heparin for catheter thrombosis, especially in the short-term catheter. There's no adverse event reported, presumptively safe to use, but we do not know the efficacy when it compares to citrate. The other outcomes they evaluated will be exit site infection. In this study, it's about 6% exit site infection in the heparin group versus 9% in bicarbonate group. P-value did not reach the statistical significance. So it's safe to say both heparin group and bicarbonate group have a low accident of exit site infection. But one thing they did not evaluate in this study is the blood culture, because the other big thing we talk about when we talk about lock solution is anti-infective property. So they did not do blood culture routinely. They say that's not their aim of for the study, but based on the other paper I did refer earlier, that's 2019 study, they did talk about there's a low incidence of catheter losses due to catheter-related bloodstream infection in bicarbonate group than saline group. So it's 0.4% in the bicarbonate group for the catheter losses because the infection. Like I say, the paper is not perfect. It does have a lot of typo and at least one citation mistake. It is a single center study, and they didn't really talk about a lot about catheter-related bloodstream infection. It's not documented in the paper. And they also, the author in the limitation section, they also suddenly talk about C-reactive protein. They talk about the C-reactive protein decreases as the treatment continues. They kind of somehow implied that even though it is not a marker for catheter-related bloodstream infection, but perhaps there's unlikely occurring because the C-reactive protein is decreasing, not instead of increasing. But they didn't really do any statistics in the C-reactive protein or talk more than just one sentence. And lastly, they also talk about they initially they did not directly visualizing the removed catheter for all the patients, so they had to add more patients later on in order to overcome that initial over initial I shouldn't say mistake, the initial design flaw. So overall, despite the flaws in this paper, I still enjoy reading it because it's just a different approach for the lock solution. At least based on the paper and some previous paper, I would say heparin is pretty safe, looks like it's pretty safe with no reported side effect. And based on this paper, sodium bicarb and heparin had similar success rate in preventing catheter-related thrombosis. And sodium bicarb can be considered if we want to avoid using heparin, especially if you have a patient with excessive thrombocytopenia or hemorrhage or hypokalemia or even skin necrosis. Then at least currently, based on what we have so far, it's likely applicable for patients with non-tunnel catheters, but long-term studies still needed to investigate the catheter-related infection, and also if we're using the catheter longer than, say, 1 to 2 weeks, is it still safe to use? That's still a question, answers unknown. So this is what I have prepared. I know it's a little bit short because the paper itself is not that long, and there's not a whole lot of other prior papers talking about bicarb as a lock solution. But if you have any questions or any thoughts, or you used that in the past, or you used ethanol in the past, please do share your thoughts. I would love to hear.
Thanks, Sandy. That was really great. Um, so I
Thank
think I was really interested in this, and I looked at it as what what would be the worst case scenario that we have with our catheters, and we worry about our catheters that we can't aspirate them,
you.
and during the process of us trying to troubleshoot them, you often just need to flush, and often that could be a brisk hard flush to try to dislodge any thrombosis that could be there or free the vessel up from the fibrin sheath. You might try a slow flush to slowly push some TPA through it, but there's certainly plenty of times where we can't aspirate the lock and we just have to give it. So
Right.
in this scenario, presuming you have both lumens locked with sodium bicarb and both lumens are unable to be aspirated and you have to flush both of them, do you think that that's a high enough concentration of bicarbonate to result in any adverse effects?
I definitely worry about it, especially it's not diluted. I worry about how it's going to be any like inflammation happening if I flush all of a suddenly a lot of bicarb. That's why I've been trying to look for all the papers studying the bicarb to see if they reported any side effects. They didn't mention any of them.
Right.
But yes, that's my big, actually, it's the biggest, my biggest question when I read them, but there's nothing reported. So I guess I will be really worried if I use sodium. I definitely wouldn't use sodium bicarbonate as my first solution because what you mentioned, JD.
Yeah, because we kind of calculate our concentration of heparin in the
Hmm.
lumens as according to that worst case scenario, that if we have to flush both of them, what's the dose of heparin that the patient's going to get? And, I'm probably pretty comfortable if they get 100, maybe 150 units per kilo, because we use that as fairly standard dosing for IMHA patients and things like that. but I'm probably a bit more nervous if I'm putting in 300 units per kilo cumulatively in both of those lumens in case I need to flush. And
Right.
we kind of think of the same thing with those really high, like the 23% citrate concentration solutions. Um,
Hmm.
Perhaps if we have to flush it rapidly, it could chelate calcium and potentially just result in the heart having temporarily a very low ionized calcium concentration and cause arrhythmias or complications. So the same potentially could be said with bicarb. But what would be interesting is, let's say we have a Labrador who has a 14 French non-tunneled catheter in place. They might have maybe probably just shy of 2 mils in each of the lumens. You're probably somewhere around like 1.6
Hmm.
mils or so. So let's just say
Right.
worst case scenario, let's say each lumen has 2 mils. So cumulatively, it has 4 mils of locking solution, and we're locking with the 8.4% bicarb, which is 1 mil equivalent or 1 millimole per mil as a concentration. Um, if we were to flush that, then the patient would be getting a total of 4 mil equivalents. And for a Labrador, let's say a 30 kg Labrador, that's going to be, what's that? Just about zero point 0.1 mil equivalents per kilo. So it's a fairly kind of lowish dose, especially when you look at what's given for the treatment, let's say, of hyperkalemia, because certainly treating acidosis, we normally dose it based upon their bicarb deficit. But if we just look at hyperkalemia, the doses are usually 1 mil equivalent per kilo over, some show as little as like 3 to 5 minutes. Others are like 1 to 3 mil equivalents per kilo over maybe 10 to 15 minutes. So initially I was thinking, I'd be really scared about that. But then when I do the math, unless I mess up the math, which is definitely possible, it's actually a pretty low dose of bicarb. And I wouldn't want to flush it, but I think it would probably still be relatively safe if you needed to, because it is such a small dose. If you compare, the Labrador, if we were giving it for hyperkalemia, which hope everybody remembers that that's not an appropriate therapy for hyperkalemia. But let's say someone would, they probably would be getting 30 mil equivalents over maybe 3 to 5 minutes or so. So I think I would probably still think it would be relatively safe, although I don't have any data to back that up. But I think the math would still favor that it's not as if we just gave the therapeutic dose of bicarb over a 10-second flush. Maybe the patients could actually tolerate it. So I'm not sure if anyone has used it or had any thoughts based upon that math, whether they feel more or less comfortable. But I was initially scared, and now I feel like I'm less scared after doing some math.
Thank you for doing the math. I didn't do the math, but because I was all thinking about like the osmolarity of the bicarb. So
Hmm.
that's the one part I'm kind of worried about because usually it's about almost like 2000 milliosmol per liter. I know the central catheter should be able to tolerate better, but it's still really high. Um, but I think if it's safe dose to use, but at the same time, I still worry about the osmolarity, the hypertonicity to
Yeah,
it.
yeah,
Yeah.
that's a good point.
Thank
I
you.
think the one thing that I found interesting is like we have pretty long catheters in relation to, humans. And I think ultimately, are we going to see some of the same benefits that they would see, the leg versus the central line? I think brings up a good question. And that was just kind of my observation.
Yeah, the catheter length they're using is like 20, even just for femoral is 20 centimeter and 15 to 17 for the jugular. So yeah, I don't know the answer to that.
Yeah, thank you for the presentation, Sandy. Definitely interesting topic, I think, as we all like kind of default to heparin for our logs, but there might be more to look at. And after your presentation, I will definitely not look at my heparin vial the same. As far as the effect of the bicarbonate, I think the study you mentioned that was discontinued because we had more thrombosis event, the concentration of bicarb they were using was different. It was 7.5 versus 8.4, I think, which I don't know if that can be a factor explaining maybe the discrepancy between those two studies. But and also they didn't mention like what concentration of heparin they were comparing to, I think.
Thank you. Yeah, I actually didn't have access to that paper. I was
Yeah.
just reading the abstract.
Yeah, but this one, the
Mhm,
Watanabe that's in a paper,
yeah,
definitely
yeah.
the was 7.5%, and that was versus 2,500 units of heparin, which is
Okay.
different than the study you presented.
That's interesting because I thought bicarb usually come as 8.4%. They probably diluted on purpose or something. It's interesting.
Yeah, I don't know the details. It might be a regional difference
Yeah,
too. I don't.
possible. Any other thoughts or questions, or have anyone used any crazy solution as a lock solution in the past? Or would you consider using bicarb or ethanol as a lock solution?
I think I would consider bicarb based upon this. I would be interested, especially, and we have some patients, I think we all have them, that you have the same concentration of bicarb, of heparin in their catheter, and one patient's just super clotty, and you're dealing with catheter dysfunction, and the next patient, it is really well tolerated, and they're not having much. And so for one of those patients that might be still having catheter dysfunction, or we're dealing with clots despite me giving my maximum dose of heparin, I think it would be certainly something that I would give a shot. I think I would consider it. I'm also, I think, and I thank you for including, like, just thinking about the carbon footprint of it as well too. I think that's a really important concept that we should probably keep in mind. Dialysis is extremely wasteful and resource intensive, so anything we might be able to do to reduce that would be pretty fantastic. So I don't know if I'm ready to make the jump completely, but I think for the patient that's really having thrombosis problems, and we're dealing with the catheter being super sticky every time we access it, yeah, I think I'd probably give it a shot personally.
Thank you. Really appreciate it. I think the same way. I think, especially for my patients, if I see a lot of side effects from heparin, I will consider trying this as well. Um, okay. If I don't see any question in the chat, I guess does anyone have questions or any comments before we ended the discussion?
Maybe just an aside question. Who else is using like multimodal anticoagulation in their patients systemically? I just feel like here at altitude, I see a lot of thrombosis for a number of factors. And we're definitely doing both like a 10A inhibitor and Plavix. So just curious if anyone else is doing that.
Some patients, but I think they are probably giving us some indication that they're hypercoagulable, or we're dealing with thrombosis around it. That's when we're going to reach for the 10A inhibitor. Otherwise, we would consider Plavix in most patients, but probably not all. It's certainly not standard of care in people to use anticoagulants for catheters. So I would say we have some patients that we never put them on any anticoagulant. If we do, it's probably going to be Plavix. But then if they are having if they have an increased risk, then we might do dual therapy or just a factor 10 inhibitor. So I think we're probably a bit too variable to say that we follow any specific rule here at Friendship.
Yeah, I'd echo that. For me, they have to earn the second therapeutic. But it sounds like, Dan, maybe in your population they do earn it pretty quick.
Yeah, they pretty much all go on it. They've just had too many what look to be PTEs, and then just dogs that come in with aortic thrombi in general. So it's a very different population, I would say.
I guess any other questions or comments at this point? Well, thank you all for coming and joining me this afternoon. If you have any questions or any comments or you have any thoughts, please let me know. Otherwise, sorry, just want to show you my email, but I lost it. But anyhow, thank you for joining me, and I really appreciate it. You have a great afternoon.
Thank you.
Thanks, Andy.
Thanks,
That was
Andy.
really great.
Thanks,
Thank you.
Andy.
Thank you.